Thank you to the Cervical Spine Research Society for allowing me to participate in the symposium on the safety in cervical spine surgery. I'll be talking today about safety of cervical spine surgery that is being done in an outpatient setting. I think the first thing that's important when we're talking about safety in outpatient surgery is having an understanding of what outpatient surgery is. For the purposes of this talk, we will define outpatient surgery as patients who arrive and leave the same day of procedure. This is different than perhaps outpatient surgery as is determined by your hospital administrator, or even outpatient surgery being done in some ambulatory surgery centers where patients are kept overnight for observation for 23 hours. The potential benefits and the reason why many of the stakeholders are interested in outpatient surgery are because outpatient surgery is driving important medical advances in terms of patient satisfaction, economics, and even the type of medicine that we're providing. I would say that in some settings, doing a surgical procedure as an outpatient provides increased safety, but we'll get into that as we move forward. The hallmarks for a successful outpatient procedure are that it should be as minimally invasive as possible. It should be a procedure that comes with low blood loss. There should be minimal surgical pain, and the complication profile should also be minimal. In my current practice, the procedures that I consider doing as outpatient include lumbar decompression surgeries, cervical decompression surgeries done through a posterior approach, anterior cervical discectomy and fusion surgeries, and cervical disc arthroplasties for 1 and 2 level procedures. Now, when we're thinking about ambulatory surgery and its safety in the cervical spine, the procedure that drives most of the controversy is the anterior cervical discectomy and fusion, or really any anterior-based cervical operation. The reason for this is that there are the potential for major complications in anterior cervical discectomy and fusion that can be life-threatening, involving a patient's airway. A quality analysis that was done of anterior cervical discectomy and fusion surgery in an outpatient versus inpatient setting by the group out of Vanderbilt had shown that 1 and 2 level ACDF could be performed safely in outpatient ambulatory surgery settings for patients who are appropriate candidates. This paper, which compared the short-term complications of inpatient versus outpatient single-level ACDF surgery using a national database, found that preoperative and operative characteristics played a significant role in the safety of ambulatory anterior cervical surgery. And in this paper, the authors found that the mortality after surgery done through an anterior approach for single level ACDF was equal and extremely low in both the inpatient and outpatient groups. As surgeons, we're often asked by patients to talk about risks. This was a paper that was done out of the group in Yale that found interesting findings when members of our society, the Cervical Spine Research Society, were asked about anterior cervical discectomy and fusion in particular. We overestimated the risks such as UTIs, DVTs, blood transfusions, but we underestimated risks such as death, return to OR, and readmission. So we do think that anterior cervical discectomy, appropriately so, is a very safe operation. However, we sometimes will underrepresent to patients and perhaps to ourselves the likelihood of readmission, return to OR, and death. This was a paper that I was involved in and publishing, and we looked at just when surgeons decide what kind of surgeries they're going to do in an ambulatory setting. And the trend here was that if there was a financial stake for the surgeon in the ambulatory surgery center, that surgeon could be considering higher risk procedures to be done in that surgery center. And this is an important finding because perhaps this finding was because these were expert surgeons doing these surgeries in ambulatory settings and felt very comfortable with it. Or perhaps there were other drivers. And I think as physicians and surgeons, we always have to put our patient's safety first, and it's an important consideration to make. The real issue here with anterior approaches in the cervical spine is the devastating airway compromise that can occur in certain cases and in certain patients. This was a study that was done by Dan Rue, looking at the prevalence and outcomes in patients who had to undergo reintubation after anterior cervical spine surgery. And what they found was that the time to development of airway symptoms after surgery was primarily within 24 hours. And while the prevalence of reintubation was low, the complication, meaning having to be reintubated, did worsen a patient's clinical outcomes. On the other hand, this was a study that was done out of our institution at a hospital for special surgery that found that if the airway was adequately restored in a timely manner in this emergent setting, that outcomes for patients in general were favorable. So we could see that this continues to be a controversial topic. Ultimately, I think what's important is to try to figure out what risk factors are associated with either prolonged intubation or reintubation after anterior cervical surgery. This was a nice study done out of Korea that showed that patient age, comorbidities, and operative factors all played a role in either prolonged intubation or reintubation after anterior cervical surgery. And when that same group looked at airway management protocols, what they found was that the specific factors that increased airway complications included indications for surgery, medical comorbidities, and the type of surgery that was being done, very specifically how long the surgery was taking. This study looked at the relationship between ASA score and the likelihood of 30-day readmission in patients undergoing ACDF, and found again that a high ASA score, along with medical comorbidities, resulted in an increased likelihood of unplanned readmissions. We've attempted in surgical procedures to see if there are ways of reducing swelling. And this study that looked specifically at the administration of dexamethasone perioperatively found that this resulted in significantly improved swallowing function and airway edema, and thus shortened length of stay. So certainly, something to consider when we're thinking about outpatient anterior surgery. This study, again, done out of the Yale group using a large database, looked to determine the incidence, timing, risk factors, and potential clinical implications of postoperative hematoma, specifically that required reoperation, which is obviously very important. And what they found was that of the almost 40,000 ACDF patients that they looked at, less than 200 developed a hematoma that required reoperation. So a very small percentage, 0.4%. Now, of the cases that did develop this complication, 37% did occur after discharge. And this can be a scary thing, because if this occurs after discharge, that can be quite concerning as a life-threatening emergency for the patient as timing becomes very important. This study done by the Vanderbilt group looked at 1,000 consecutive patients who underwent ACDF in an outpatient setting. And what they found was that outpatient ACDF complication rates were low. Of course, they chose patients with low ASA scores and 1 and 2 level surgeries. And they felt that a 4-hour observation window in the recovery room at the ambulatory surgery center was a safe way to go. This was a paper that we have published recently looking specifically at 2-level ACDF. This was, there's been, most of the published data has looked at either just single-level ACDF or both 1 and 2-level ACDF. What we wanted to determine here was the safety of two-level anterior cervical discectomy and fusion done in an ambulatory surgery setting. And again, what we found was that patients who had a lower ASA class, a lower BMI, shorter operative times, and thus a short length of stay, were safe to do in an ambulatory surgery setting. Another paper that we did on the topic looking at outpatient multi-level ACDF, so this was looking at specifically 2 and 3 level ACDFs. Again, what we found was that surgeons specifically chose younger, healthier patients and were more likely to do 2-level surgery than 3-level surgery in an outpatient setting. So again, I think it's important to continue to consider the fact that when selecting patients to be done in an outpatient setting, those medical comorbidities, their ASA class, and the type of surgery that we're considering doing are the real critical factors in decision making. Our group also looked at outpatient 2-level cervical disc replacement, and again, we found similar findings in that patients who were had a lower BMI and ultimately a lower ASA class underwent outpatient ACDF quite safely when doing 2-level cervical disc arthroplasty. My personal protocol for outpatient procedures in the cervical spine, the procedures that I like to do are the posterior cervical foraminotomies, either at 1 or 2 levels, 1 or 2 level ACDF or cervical disc arthroplasty in the appropriate patient from a medical perspective. Maximizing outpatient discharge success is critical to this being done safely. So preoperative patient education is an absolute necessity here. You have to minimize the perioperative narcotic dose, and then selecting the right patient, as we've seen in study after study. My personal protocol is shown here that an outpatient should have a BMI that's less than 40. They should be healthy. They should live or stay close to a hospital within 30 minutes is our criteria. They don't have to stay within 30 minutes of our hospital, but just any hospital that they have identified that they would go to in case of emergency. They must have a responsible adult with them for at least 24 hours and an ASA class that's less than 3. We limit the narcotic during surgery as well as the IV fluids. I generally expose just 1 level at a time, only retracting at the disc space. I try to make sure that my retractor time is limited to less than 30 minutes per level. But again, of course, doing everything that needs to be done to have to perform a good surgery for decompression and fusion. I do not use drains. I make sure that we have excellent hemostasis. I keep the patient in recovery for approximately 5 hours, during which time they must ambulate. They must be comfortable without narcotics other than tramadol if needed. They must be able to void twice and eat solids twice. The most common reasons that I have found patients to need to stay are in those patients who have any nausea, vomiting, if they have more significant pain than what is expected, and certainly if there's any surgical complications. I think it is always better to keep the patient for observation overnight. We have developed with our anesthesia group collaboratively a pathway for enhanced recovery after cervical surgery. These were patients of mine that underwent 1 and 2 level anterior cervical surgery, either disc replacement or fusion. And what we found was that patients who were baseline opioid tolerant did require more intraoperative opioid administration and more administration of opioids in the PACU, versus patients who were baseline opioid naive, required less opioids. And so getting patients off of opioids preoperatively is important. And what we ultimately found here was that we were able to facilitate a safe and prompt discharge. We had no readmissions within 30 days, and we felt that we had identified a safety element in our pathway, which was unique in that we had a specific protocol for outpatient surgery, starting from the preoperative period through the perioperative period and then through discharge. My take-home points here would be that ambulatory surgery, as we all would agree, is an increasingly important segment of spine surgery. Patient selection is critical. Indications are expanding in cervical spine surgery in particular. Both anterior and posterior procedures can be done safely, but it's important to make this a mutual decision between the patient, the surgeon, and the anesthesiologist, because safety comes first. identify those patients that are healthier, have a lower ASA class, a lower comorbidity status, and a surgery that you feel very comfortable doing safely, effectively, and efficiently. Thank you.